It's Professor Rich. I'm going to be going through the GI and musculoskeletal disorder PowerPoint. This is 2 PowerPoints combined into one. The first portion of this PowerPoint is on gastrointestinal disorders. Goes over the objectives. We're going to do a brief review of the GI system, oral cancer, esophageal cancer, GERD, hiatal hernia, gastritis, gastroenteritis, PUD, gastric and colorectal cancer, hemorrhoids, IBS and IBD, celiac disease, diverticulitis, appendicitis, hepatitis, cholecystitis, pancreatitis, and pancreatic cancer. Very brief overview. If you need more, then please refer to your F.A. Davis book. The GI system consists of 2 divisions. So there's the alimentary tract and the accessory organs. Normal intake is through the mouth. However, patients that have disorders affecting their ability to eat or swallow, nutrition can be delivered directly into the stomach or small intestines. Digestion begins in the mouth and continues into the stomach and small intestine. The large intestine is primarily responsible for the reabsorption of fluids, electrolytes, and elimination of waste products. Equally important to the normal function of the GI system is the role of the accessory organs, which is the teeth, tongue, salivary glands, liver, gallbladder, and pancreas. Normal functioning of the GI system also includes actions of the nervous and endocrine systems. Physical exam, we must start with the mouth. Inspection of the oral cavity offers insight into the GI and oral health. To assess the abdomen, the patient should ideally be positioned in supine position with their arms relaxed at their sides and their knees bent in order to promote relaxation of the abdomen. Using indirect lighting and tangential views, the nurse must inspect the skin for color, striae, lesions, presence of superficial vessels, and scarring. The contour, shape, and any abnormalities of the abdomen are noted. The abdomen should be slightly concave to round. After inspection, we auscultate. Normal bowel sounds can range from low to high-pitched gurgling, and the frequency of bowel sounds can occur at a rate of 5 to 30 times per minute. Hypoactive bowel sounds can be caused by anesthesia, opiates, and anticholinergic medications, as well as conditions such as constipation or ileus. Hyperactive bowel sounds can be secondary to the actions of cholinergic medications or infection or inflammatory bowel disorders. Percussion over the intestinal area should elicit a drum-like sound known as tympany. This sound is similar to the sound heard when percussing a balloon filled with air and should be predominant sound of the abdomen because air rises in the intestines when patients are in a supine position. Percussion over the liver or stomach should elicit a dullness sound, a flat sound. This is similar to when a balloon is filled with water and tapped on. Dullness can also be heard in an obese abdomen, over the intestinal tract when filled with fecal matter, over a full bladder, or the presence of a fluid accumulation in the abdomen known as ascites. Palpation. During palpation, it is important to note the abdominal tone and any areas of tenderness. Palpating large abdomens in obese patients can be difficult because of the increased pressure met against the palpating hand. To the left, you can see how the abdomen is divided into 4 quadrants. It is important to know the anatomy and which organs are located in which quadrant. Percussion and palpation can manipulate the abdomen, resulting in an inaccurate interpretation of vowel sounds as being hyperactive. So auscultation is completed after inspection. So please always listen before you palpate. Hydration. So I just want to say I'm very proud of this SpongeBob GIF, whatever it's called. Anyway, what are the signs and symptoms? Signs and symptoms of dehydration include weight loss, decreased skin turgor, concentrated urine, oliguria, thirst, and dry mucous membranes. Severe rapid fluid losses can be seen in hemorrhage, burns, or extensive losses from the GI tract. Additional signs and symptoms observed with significant fluid loss are weak, rapid peripheral pulses, flattened neck veins, hypotension, anxiety, restlessness, and cool, clammy, pale skin. Assessments. Which assessment is priority? Cardiac, but why? Dehydration places a patient at risk for cardiac issues related to electrolyte loss. So cardiac is priority, but we also need to do a thorough neuro, GI, GU, and renal assessment. We should be documenting daily weights on our patients. If a patient's dehydrated, we would see a downward trend. If the patient's showing signs and symptoms of dehydration, we could do a 24-hour intake and output calculation to determine if the fluid is balanced. Did the patient take in more than they put out? Interventions. Please look over NG tube insertion. So I'm going to go over basic things. Why would we insert an NG tube? For one, feeding purposes, so we can give them an intake. We can give them some kind of nutrition. Abdominal decompression. We would have them up to suction. A small bowel obstruction, so whatever's in their abdomen can't pass through, so we want to suction it up. So for SBO. Inserting, again, please look it over. We want this patient in a high Fowler's position with a pillow behind their head and shoulders. This position can facilitate tube insertion and prevents aspiration if the patient were to vomit during tube insertion. Gravity also will facilitate the tube going down. Raise the bed up to prevent strain on your back. Let's see. So you're going to insert your tube, secure it, and then confirm placement. To confirm your placement, you're going to push air into the tube and listen over the belly for a gurgling sound. You can assess the drainage, check the pH of the aspirate. Biggie, get a radiograph for the initial. We want to get an x-ray or some kind of scan to see that it's actually in. Then we want, before we initiate feedings, and every 4 to 8 hours, we want to, again, check our placement. We want to monitor and document drainage. And also keep in mind, these patients need frequent oral care. We can't forget about their mouth. TPN. This is a last-ditch effort to treat malnutrition and malabsorption. If a patient's unable to intake oral nutrition and we try an NG tube and that fails, that's when we're kind of looking at TPN. This must be given through a central line. TPN provides the major macronutrients such as protein, carbohydrates, lipids, as well as micronutrients are electrolytes, vitamins, and trace minerals. It also provides the patient with water. So big thing, why are we giving TPN? Malnutrition or malabsorption, unable to take or intake oral. Testing. I am not going to go through everything. There is a big box in F.A. Davis on page 1272. It's box 55.8. Please look over the different tests. You'll have a description, rationale, special considerations, if they should be MPO or not, what they're looking for. Please review this box. As throughout the PowerPoint, I will put for different disorders what our big testing is for it, what the major testing that we do for each disorder is. Cancer. This is going to be a brief overview as cancer is a specialty. Risk factors for oral cancer include increasing age, male, intense exposure to the sun, excessive alcohol consumption, and pipe or cigarette smoking. The clinical presentation of cancer of the oral cavity usually includes the floor of the mouth or the tongue. Patients are often asymptomatic in the early stages, and symptoms come later. The later symptoms are oral bleeding, a raised area, ulcers, patchy areas on the lip or in the mouth, pain in the mouth, trouble speaking, chewing, or swallowing. They may also have an odor in their mouth. Diagnostics include labs like a CBC, CMP, liver function. They're going to have a CAT scan of their head and neck, an MRI of their head and neck, and a chest x-ray. Treatment includes chemotherapy, radiation, airway management, and nutrition management. Esophageal cancer. This is a brief overview again. Cancer is a specialty. Esophageal cancer develops in the mucosal layer of the esophagus and grows outward into the submucosal and muscular layers. It can occur in any part of the esophagus. Non-modifiable risk factors include age, sex, and race. Modifiable risk factors include alcohol and tobacco use. Other risk factors include nutritional deficiency, Barrett's esophagus, long-term untreated GERD, and obesity. Progressive dysphagia is the most common symptom of esophageal cancer, and it indicates a large late stage of cancer in most cases. Other signs and symptoms are hemoptysis or coughing up blood, epigastric pain, painful swallowing, vomiting, weight loss, anorexia, a hoarse voice, and melena. To diagnose the esophageal cancer, the patient can have a barium swallow, CT scan, PET scan, or endoscopy. Treatment for this type of cancer is usually surgical, removing the tumor. Nursing management includes preventing and monitoring for aspiration. This is the big thing, aspiration and respiratory complications. These patients need to sit upright for meals. They should have semi-soft fluids and thickened liquids. We should be listening to these patients' lungs after meals to assess for aspiration. Consult the nutritionist. This patient might need calorie counts. They're going to need that altered diet, that soft diet. They might need nutritional supplements. They're going to need food and fluids to prevent weight loss and promote healing. We should do a diet that is high in fats, high in protein, and low in sugar. So doing smaller meals with a decrease in complex sugars with foods high in fat and protein can help delay gastric emptying and prevent dumping syndrome. Dumping syndrome is one of the post-surgical complications, which is when the patient has severe diarrhea after eating. They literally dump out all of their intake. So big thing for esophageal cancer is preventing aspiration, because if we have something going on in our esophagus, blocking food or whatever, it can make us, aspirate, make us choke. Gastroesophageal reflux disease, commonly known as GERD. This is a chronic disorder that describes a variety of clinical manifestations with or without tissue damage. It's caused by acid reflux from the stomach or the duodenum into the esophagus. The lower portion of the esophagus that connects to the stomach is called the gastroesophageal junction, or GEJ. Below the GEJ is a muscular area called the lower esophageal sphincter, or LES. The purpose of the LES is to allow food from the esophagus to enter the stomach, but to prevent contents from the stomach from entering the esophagus. When there's a decrease in LES pressure, the acid can backtrack up the esophagus, causing GERD. Each episode results in hyperemia, which is increased blood flow, erosion or ulceration, and possible minor bleeding to the esophagus. During reflux, other gastric substances such as pepsin and bile may also be present. These substances, like acid, are caustic to the esophageal epithelium. Common causes of GERD include hiatal hernia, increased gastric secretions, eating large meals, obesity, pregnancy, and ascites. Signs and symptoms of GERD are heartburn, atypical chest pain or epigastric pain, difficult or painful swallowing, and bronchitis. Diagnostics include a 24-hour ambulatory esophageal pH monitoring and an EGD. That 24-hour ambulatory esophageal pH monitoring is when they take a catheter and put it through the nose and it terminates at the distal esophagus, and they do continuous measurement of the gastric pH and record it throughout. The EGD is a scope through the mouth down to the esophagus, where biopsy samples can be taken, or if there's any strictures, they can be dilated. Strictures are a result of fibrosis or the scarring related to the injury of the acid exposure. Treatment includes antacids. We can give histamine receptor antagonists, prokinetic medications, and proton pump inhibitors. Lastly, they can have a laparoscopic Nissen fundoplication as a procedure. Hiatal hernia. So a hiatal hernia occurs when a portion of the stomach protrudes upward through the esophageal hiatus. So that opening in the diaphragm that the esophagus passes through and into the thoracic cavity. So the incidence of hiatal hernias increases with age as supportive structures weaken. Approximately 60% of those affected are older than the age of 50, and 9% of those are symptomatic. So a very small percent are symptomatic. A hiatal hernia is usually found incidentally when a patient's being evaluated for a different issue. Diagnostics, they focus on upper GI, so an EGD is the big one. They might have an upper abdominal x-ray, barium swallow with a fluoroscopy. That's the most specific test, is that barium swallow fluoroscopy, and that obviously that EGD. So as stated, symptoms are rare, but when they are present, it's very similar to GERD, and GERD is the most common complication of a hiatal hernia. The symptoms are usually worse after meals because of the displacement of the stomach contents into that thoracic cavity. Lifestyle changes can reduce those symptoms, and the same medications that are prescribed for GERD are also prescribed for a hiatal hernia. Surgical intervention may be necessary, and again, that's that Nissen fundoplication. If they were to do that, it's laparoscopic, it's the gold standard treatment. It's performed through several small incisions in the abdomen. Postoperative complications include infection, bleeding, atelectasis, pneumonia, obstructed NG tube, gas bloat syndrome, so remember Walker patients, temporary dysphagia. We should educate these patients to limit spicy, fatty foods, caffeine, chocolate, carbonated beverages, acidic foods, peppermint, alcohol, I think I already said caffeine. I'll say it again, caffeine. And certain medications such as calcium channel blockers, anticholinergics, and smooth muscle relaxers, because that's going to relax it further. We should encourage the patient to eat small meals in 2 hours before lying supine. So they should eat 2 hours prior to lying flat. They should sit upright after eating. We should educate them to wear non-restrictive clothing because tight clothing can cause an increase in intra-abdominal pressure, which will weaken the LES and also make GERD worse. They should try to maintain a normal weight. And then there's more information on that laparoscopic Nissen fundoplication in F.A. Davis. It's box 56.1. So this is localized or patchy inflammation of the gastric mucosa, and it could be acute or chronic. It results from repeated exposures to irritating agents or recurring episodes of acute gastritis. The clinical presentation of gastritis is associated with the damage of the gastric mucosa and typically includes epigastric pain, nausea and vomiting, weight loss, decreased appetite, and changes in the color of the stool. Causes, medications such as aspirin, NSAIDs, alcohol, bile salts, H. pylori infection. That's a key cause of chronic gastritis. Environmental factors can also cause this. They should avoid spicy foods and foods that can exacerbate their symptoms. To diagnose it, we would do an upper GI X-ray series. We could do an endoscopy, histological exam. The treatment includes antacids. So antacids are used to neutralize the acid. A PPI such as famotidine is used to decrease the production of gastric acid. Sulfate or carafate, it has no effect on the gastric pH, but it provides a physical barrier protecting the lining of the stomach from the acid. And the diet, they should have small frequent meals and avoid spicy foods. Gastroenteritis. This is also stomach flu or food poisoning as we commonly know. So it's acute inflammation of the gastric and intestinal mucosa. It's commonly due to bacteria, could be viral, protozoal, parasitic. Bacteria is more common in the summer with undercooked foods from the grill. It can also be caused by irritation of a chemical or toxin. Symptoms are self-limiting. They may need prescription medication to resolve them. Older patients are more likely to be hospitalized. They can get dehydrated, which is the most common complication of gastroenteritis. Best method of prevention, we should be hand washing. Signs and symptoms, but to go with best method of prevention and hand washing, but also cooking foods thoroughly. Signs and symptoms include nausea, vomiting, diarrhea, abdominal pain, abdominal distension, fever related to the infection, anorexia, malaise, headache. As a nurse, we're really looking for signs of dehydration, which I included previously, but dry, flushed skin, dry mucous membranes, decreased urine output, tachycardia, poor skin turgor, decreased skin turgor, orthostatic blood pressure changes. Common tests, CBC would show an elevated white blood cell count because it's showing infection. Electrolytes, we want to be looking for imbalances related to the GI loss. BUN and creatinine, we're going to evaluate for dehydration. So if we're dehydrated, our BUN is going to increase. Remember, high and dry. The stool can be evaluated for parasites. Treatment involves monitoring INO, stop oral intake if there's vomiting, and resume when the nausea subsides with like a clear liquid, and then progress the diet as tolerated. Replace lost fluids with IV. Give antiemetics for nausea, vomiting. You could give an antidiarrheal like loperamide if needed. We do want the infection to clear one way or another. So if they're vomiting and having diarrhea, we really shouldn't give a antiemetic and an antidiarrheal, because then they're just keeping that infection in to fester. So we do want it to get out one way or another. If it's bacterial in cause, we want to give some antibiotics. Peptic ulcer disease, PUD. So it's an ulcer in the GI tract that can be defined as a break in the lining of mucosa. There are two major forms of peptic ulcers. There's duodenal, and the symptoms from this are burning epigastric pain. Usually it's worse when you're hungry, so it's aggravated by fasting, but it improves when you eat or take an antacid. And then there's also gastric ulcers. These are worsened by eating. So that's a big difference. Duodenal get better with eating. They're worsened by fasting, and gastric are triggered by eating. And usually so they occur shortly after you eat, and there's not really much relief from an antacid for the gastric ulcers. Erosions result from the corrosive action of acid gastric juice on a vulnerable epithelium. It's caused by an imbalance between mucosal defenses and acid peptic injury. The damaged mucosa cannot secrete enough mucus to act as a barrier against the gastric acid, so that's why the ulcer forms. NSAIDs, aspirin, H. pylori, alcohol, and caffeine are common causes of PUD. An upper GI endoscopy is the preferred procedure to evaluate for it. There are other options there, upper GI x-rays with the barium, histological exam, but again, that upper GI endoscopy is the preferred way. Complications of PUD are GI hemorrhage, and that would be presenting as black tarry stools. Abdominal or intestinal infarction, perforation's a big one. Any perforation that ever happens is really bad. Symptoms of perforation are sudden sharp abdominal pain, rigid abdomen, declining peristalsis, so declining movement within the bowels. Vital signs will change quickly because rupture will be bleeding. If that ever is to happen, call the doctor immediately, because that patient's going to become septic and hypovolemic. It's bad. Common treatment for PUD includes PPI such as omeprazole, NSAIDs, H2 receptors. The diet, they should avoid irritants, so they should avoid spices, alcohol, and caffeine. Big ones. PUD should avoid spices, alcohol, and caffeine. They should consume 6 small meals a day. every few hours is more encouraged. Intake adequate fluids, avoid aspirin. There are some minimally invasive procedures that could allow ulcers to be removed and control bleeding. More conventional surgical interventions are indicated for perforation or lack of response to conservative treatment. Gastric cancer, again, quick overview. It's the second leading cause of cancer mortality in the world. Usually stomach cancers are asymptomatic until late into the disease process. When they do have symptoms, it's usually nonspecific. It could be indigestion, anorexia, weight loss, vague epigastric pain, vomiting, or an abdominal mass. The patient can experience ulcer-like pain unrelieved by antacids, typically after meals. While the disease progresses, the patients can be anorexic. An abdominal mass can be palpable. Let's see. They might have massive hematosis or melena, black tarry stools with foul odor. This is from degradation of blood in the small intestines and colon. It's uncommon. Diagnostics include a barium X-ray, endoscopy, cystology. Treatment, antiemetics to treat the nausea, opiates for pain relief, vitamin supplementation, surgical gastric resection, chemotherapy, and radiation. Complications of that gastric resection are dumping syndrome, which I briefly spoke about earlier, wound infections, leaking of the anastomotic sites, strictures, and internal bleeding. Colorectal cancer. This involves the rectum and large intestines. Most of these are adenocarcinoma. Risk factors are a personal or family history, inflammatory bowel disease, so IBD, physical inactivity, obesity, so BMI greater than 30, high-fat diet, high diet in red meat, processed meats, cigarette use, and alcohol intake. Colon cancer risk is reduced with higher intake of high-fiber foods, brassica vegetables such as broccoli and cauliflower. In the very early stages of colorectal cancers, the symptoms are insidious and can be ignored by the patient until the disease is advanced. Signs and symptoms vary. It depends on where the cancer is located in the intestine. But common symptoms are unexplained weight loss and fatigue, change in bowel regularity, appearance of the stool, they could have blood in the stool, abdominal pain, abdominal distension, a sensation of pressure or like incomplete emptying of their bowel, anemia. Treatments are chemo, radiation, and surgery to remove the affected part of the colon. Hemorrhoids. These are swollen or dilated veins in the anorectal site. So they're varicose veins in the bum, so varicose veins in the rectum. They can be internal or external, and they can be caused or precipitated by straining during defecation, prolonged constipation, heavy lifting, prolonged standing or sitting, portal hypertension, so like a cirrhotic patient, a liver patient, increased intra-abdominal pressure, pregnancy, and obesity. It's a common disorder. It affects both men and women, but it's more commonly reported in women. Most are asymptomatic. Bleeding is almost always painless, and it's observed during a bowel movement. It's usually like streaky red. External hemorrhoids are associated with itching, irritation, and pain in the rectal area. It can be prolapsed or protruding from the rectum. Some can prolapse during defecation, but spontaneously return after. And pain may range from mild to severe. Diagnosing it is usually a visual inspection. Internal hemorrhoids can be diagnosed with a digital examination or endoscopy, or even sigmoidoscopy. Treatment's usually conservative, and it's just relief of symptoms. So cold packs, sitz baths, If that kind of therapy doesn't help within 3 to 5 days, they can be referred to a primary care provider. They have different creams, like I'm sure we all heard of, like Preparation H. Patients encouraged to consume adequate fluid and fiber to decrease constipation. They should maybe need stool softeners. Topical nitroglycerin can be used to decrease pain by the thrombosed hemorrhoids, as well as topical nifedipine. The exact cause of IBS is unknown. It's a functional disorder of the intestine. It has unknown etiology. There's no known cure. Mucosal lining of the bowel is basically unchanged. So patients having all these symptoms, but everything on the inside looks the same. It looks like there's nothing wrong. Other names are called spastic colon, nervous digestion, spastic colitis. Patients with IBS usually complain of diarrhea and or constipation. So sometimes it's, oh, I have diarrhea really, really bad, or oh, I'm always constipated. Then there's other patients that are like, I have diarrhea, then I'm constipated. I have diarrhea, then I'm constipated. So it's like alternating bouts. Commonly associated with IBS is left lower quadrant pain and abdominal distension. They also might complain of gas. Pain usually increases after eating, but it's relieved by bowel movements. Because there's no change on the inside, tests are basically like the rule-out tests. So they could do a sigmoidoscopy, colonoscopy, CAT scan, lactose intolerance, celiac test, stool culture, blood tests. They could do a bunch of different tests. Everything's going to come back normal. So basically, they're ruling out other diagnoses to diagnose IBS. Treatment aims at symptom management and diet modification. So they are encouraged to maintain a food diary and try to write down any foods that trigger symptoms. They should avoid fructose, pears, mangoes, cherries, wheat. Avoid gassy foods like eggs. Caffeine and alcohol should be avoided. They may benefit from avoiding lactose like cheese and milk. Inflammatory bowel disease. So there's two. So we're going to start with Crohn's disease, which is an autoimmune disorder that can affect any point within the GI tract, from the mouth to the anus. Damage to the GI tract, it's non-continuous. So for Crohn's, it's non-continuous. There's disease patches interspersed among healthy tissue. The majority of the cases involve the small and large intestine, and they often complain of right lower quadrant pain. It's usually at the point of terminal ileum and the ascending, like where the terminal ileum and the ascending meet. Patients typically have insidious onset of intermittent symptoms. The average age of onset is late 20s. There is an increased risk with family history, smoking, living in an urban area, industrialized areas also have an increased risk. It's a chronic disorder. It has periods of exacerbation and periods of remission. So common signs and symptoms are crampy abdominal pain, frequently in the right lower quadrant, diarrhea that's not bloody. So Crohn's is diarrhea that's not bloody, abdominal mass, weight loss, anorexia, fatigue, bloating after meals. Many patients will ultimately need surgery. They can have a colectomy to deal with the bowel obstruction. Development of strictures may occur. Fistulas can form. There is no cure, but there is symptom and medication management. So foods that they should avoid are milk, gluten, caffeine, cocoa, chocolate, citrus juices, cold or carbonated drinks, nuts, seeds, popcorn, alcohol. They should eat a low fiber, high protein, high calorie diet. Treatment, aminosalicylates, immunomodulators, biological therapies. They could all induce and maintain remission. Glucocorticoids could be used to reduce inflammation. Antidiarrheals to reduce diarrhea and fluid loss. They need to be used with caution though. They might need IVF or intravenous fluids for replacement. We should encourage relaxation, like maybe meditation, because stress can trigger flare-ups for these Crohn's patients. On On the bottom of this slide, I listed some boxes. I really suggest looking through them. For treatment, see box 58.4. This is for both IBD, so Crohn's and ulcerative colitis. And box 58.3 actually does a really good comparison for Crohn's and ulcerative colitis. Okay, so really just take a look at those. Ulcerative colitis. So this is the second form of IBD. It's an inflammatory disease of the large intestines. It affects the mucosal layer. So there are ulcerations in the mucosal layer of the intestinal wall and inflammation, and abscess formations occur. So bloody diarrhea is the primary symptom. Bloody diarrhea with mucus and sometimes even pus. There'll be periods of exacerbation and remission. The exact cause is unknown. There's a peak incidence from mid-teens to mid-20s, and then again from mid-50s to mid-60s. Patients with UC may have increased symptoms with each flare-up. Malabsorption of nutrients can cause weight loss and health problems. Patients will most likely need surgery to resect the affected area of the large intestine, resulting in a colostomy. There is an increased risk of colon cancer in these patients. Common symptoms are weight loss, abdominal pain, chronic bloody diarrhea with pus due to ulceration, and electrolyte imbalances related to the diarrhea. Diagnostics and treatment are similar to Crohn's. So please review those. Complications, they are dehydration, hypotension, low electrolytes, because where fluids flow, electrolytes go, hemorrhage, and nutritional deficiencies. Celiac disease. So when a person with celiac disease eats gluten, they have an immune response. It attacks the small intestine, causing inflammation and leading to damage to the intestinal villi. It lengthens intestinal cysts and mucosal lesions, which decreases intestinal cilia. That's where it gets its name. Because the small intestine is where most of the absorption takes place, these intestinal changes lead to malabsorption and malnutrition. If left untreated, these patients can develop osteopenia and other immune disorders such as type 1 diabetes and autoimmune thyroiditis. Clinically, these patients usually have diarrhea. It's usually foul-smelling, light in color, and frothy. Steatorrhea, which is that fatty diarrhea, flatulence, weight loss, and other signs of malabsorption. They may be fatigue and weak related to the malabsorption, and in severe cases, they can have severe abdominal pain and increased bleeding tendencies can be observed. It's often difficult to diagnose because the clinical manifestations are similar to other diseases such as IBS and lactose intolerance. The patient must be persistent in getting the correct diagnosis. So diagnostics are done. They could do blood tests that test for antibodies against gliadin, genetic tests, or biopsy. A lot of these patients end up getting a colonoscopy too. The only treatment is lifelong adherence to a gluten-free diet. So they cannot eat foods that contain wheat, rye, or barley in any form. So they can have soybean flour, tapioca flour, rice, corn, buckwheat, quinoa, and potatoes. Distilled alcohol, vinegars, and wine are okay. They should not have beer, ales, lagers, or malt vinegars. Diverticulitis. With diverticulitis, there's small outpoachings called diverticula. They develop along the intestinal tract. More than half of Americans over the age of 60 have developed diverticula. Diverticulosis is a condition of having diverticula. Any part of the small intestine may be involved. So diverticulosis is the condition of having diverticula. The area of intestinal tract and most commonly developed diverticula is the lower portion of the large intestine. Certain types of undigested food can become trapped in these pouches of the intestine. Bacteria multiply in that area, causing further inflammation. Diverticulitis is the inflammation of at least one diverticula. Diets that have a low fiber content, seeds, or nuts are culprits of the cause. So, diverticulitis is inflammation of the diverticula. Diverticulosis is having diverticula. So it's a condition of having diverticula. So common signs and symptoms of diverticulitis are a change of bowel habits, abdominal pain, which can be felt anywhere but is typically left lower quadrant, rectal bleeding, fever, nausea, and vomiting. Common tests done to evaluate for diverticulitis are barium enema, colonoscopy, CAT scan, and a CBC, which is looking at the white blood cells. Treatments, administer antibiotics, IV hydration, manage pain, NPO or a clear liquid diet, and surgical intervention to form a stoma if complications occur. Complications could be perforation of the diverticula, abscess formation, a bowel obstruction, or fistula formation. These patients, they need to eat a high fiber diet with fresh fruits and vegetables. They should eat whole wheat breads and bran cereals when asymptomatic. They should eat a low residue diet during flare-ups. They should avoid laxatives and enemas because they cause increased irritation of the bowel. They should always avoid dried fruits, avoid nuts and seeds, caffeine, and alcohol. Appendicitis. So appendicitis is inflammation of the appendix that can be caused by a bowel obstruction, a foreign body, or a tumor. The mucosal lining of the appendix continues to secrete fluid, which increases the pressure within the lumen of the appendix. This causes a restriction of blood supply to the appendix. The decrease in blood supply can result in gangrene or perforation because pressure continues to build. Appendicitis can occur at any age, but it's most common between teenage years to 30. Appendicitis is a common reason for emergency surgery. Common diagnostics for appendix include a CBC, which would have elevated white blood cells, a CAT scan, which would show an enlarged appendix, or an ultrasound. Common signs and symptoms are right lower quadrant pain, or pain beginning in the periumbilical traveling to the right lower quadrant. They'll have rebound pain, guarding. They could have a rigid abdomen, which is not good. Fevers, nausea, vomiting, loss of appetite, diarrhea, or constipation. If the patient has right lower quadrant pain that improves with flexing the right hip, it suggests perforation. Or if your patient's like all of a sudden like, oh my God, my pain is better, that suggests perforation. That's really, really bad. Big red flag. Patients with perforation are very high risk for sepsis and hypovolemia because they could hemorrhage. So if your patient all of a sudden their pain resolves or their pain is improving with flexing their hip, it's suggesting a perforation. You need to call your doctor. Another complication is peritonitis. So the treatment is the surgical removal of the appendix, which is called an appendectomy. These patients should be NPO and receive IV fluids until their diet's resumed. They can get pain medications and they may need antibiotics. Monitor their intake and output. Position this patient for increased comfort. They may be more comfortable on their back with their head of the bed elevated 30 to 45 degrees with their knees flexed. So again, these patients may be comfortable on their back with their head of bed elevated 30 to 45 degrees and their knees flexed. They may also feel better laying on their side with their knees flexed, kind of like fetal position. This position decreases strain on the abdomen muscles and decreases pain related to the inflammation. Do not consider heat application. If you put heat on it, you're going to increase blood flow and inflammation, which can increase the risk of rupture. So never apply heat to your appendicitis patient. This slide should serve as a quick review because you already learned about stomas and ostomies. So let's go over the 3 S's. We have skin, stoma, and stool. So for the skin, we're looking at the skin color of the stoma, and the color surrounding should be consistent with the rest of the abdomen. You're looking for any lesions, excoriations. If you see anything, document it. The stoma, let's look at the color of it. It should be pink and moist. Like the bottom right where I put healthy, it should be pink and moist. If it's dark red, purple, or black, like that upper right one, which says bad, that's a sign of ischemia, meaning that there's a lack of blood flow and there's tissue death. That's really bad. The stool. So the consistency of the stool depends on where the stoma is located. An ileostomy is going to have liquid to semi-liquid stool. An ascending colostomy is going to have semi-liquid stool. A transverse colostomy is going to have semi-liquid to semi-formed stool. Descending colostomy is going to have semi-formed stool. And a sigmoid colostomy is going to have formed stool. During ostomy education, we want to teach the patient the 3 S's. We want to teach them to be assessing their stoma. We also want to teach our patients, as they might be scared, they might be having trouble accepting this big change to their bodies. We want to listen to them, and we want to teach them about resources such as social work or a referral to a support group. For more information, please go to your book on page 1361. There's box 58.4, which has more information on ostomies and stomas. Hepatitis. This is inflammation of liver cells, most commonly due to a viral cause. It could be acute or chronic. This disease can also be exposure of drug or toxins. There are several different types. Your book has a great chart on them on 1372. Quickly, hepatitis A, transmitted by oral route, often due to contaminated water or poor sanitation. Hepatitis A can be prevented by a vaccine. Hepatitis B is normally through a percutaneous route, usually sexual contact, IV drug use, mother to neonate, or possibly blood transfusion. Hepatitis B can be prevented by a vaccine. Hepatitis C. It's transmitted through a percutaneous route, often due to IV drug use. It's less commonly transmitted through sexual contact or history of blood transfusion. However, if it is transmitted through sexual contact, it's usually because someone has an HIV infection. There is no vaccine for hepatitis C. Signs and symptoms of hepatitis include abdominal pain, irritability, pruritus, which is itching of the skin, malaise, fever, nausea, vomiting, jaundice, which is that yellowing of the skin, and laboratory abnormalities such as elevated liver enzymes, AST, and your ALT. Those are the big ones for liver, AST and ALT. There's other ones. There's elevated bilirubin, elevated serum pneumonia. They can have a decreased albumin. And go back to signs and symptoms, that pruritus, the itching of the skin. It's usually hands and feet, and it's caused by an accumulation of bile salts under the skin that cannot be processed by the liver, so that's why they get itchy. The jaundice is occurring secondary to the liver's inability to metabolize and excrete bilirubin. Bilirubin is that byproduct of breakdown of red blood cells, and it's filtered through the liver and stored with bile. I went over the labs that are specific, the ALT and AST. So treatment includes avoiding medication metabolized by the liver, avoiding alcohol, removing or discontinuing causative agents if it's drug-induced, venous hydration if the patient's vomiting, activity as tolerated, a high-calorie diet, and in severe cases, liver transplant. We want this patient to have a diet that's high in carbs with moderate fat and proteins. It takes more work to digest fats and proteins, and smaller meals throughout the day might be better for this patient. Cholecystitis. So this is inflammation of the gallbladder. It's usually accompanied with the formation of gallstones known as cholelithiasis. So basically, the blood flow to the gallbladder is compromised because of a stone blocking the cystic duct. So then bile's like trapped within the gallbladder. So majority of the patients with cholecystitis will have a gallstone. Blood flow to the inflamed area is going to be minimized. Localized edema develops. The gallbladder distends because it's retaining that bile. Ischemic changes can occur to the wall of the gallbladder. And that buildup of bile causes further irritation and pressure within that organ, causing that pain. Risk factors are obesity, rapid weight loss surgery, eating large amounts of food that's saturated in fat, so very fatty foods, pregnancy due to elevated progesterone, some genetics and medications like estrogen, octreotide, some cholesterol-lowering medications. Signs and symptoms are that right upper quadrant pain, it could be epigastric pain. Pain may be referred to the right shoulder. When the right upper quadrant pain increases with palpation of that right upper abdomen during inspiration, that's called Murphy's sign. Nausea and vomiting, especially following fatty foods. They might have loss of appetite, fever. They might have flatulence because of increased air in that intestinal tract. Itching of the skin. They can have clay-colored stools. Diagnostic tests. Sometimes they'll do an abdominal x-ray. You might do an abdominal ultrasound. That's a little bit more common. They could do a CAT scan of the abdomen. They might do a HIDA scan. That's a nuclear medicine scan. It uses radioactive tracers to study the production of flow of bile, visualizing the liver, gallbladder, bile duct, and small intestine. In ERCP, that allows visualization of the common bile duct where gallstones can actually be removed. If the patient is going to have an ERCP, they shouldn't eat or drink anything the night before the procedure because they'll be sedated for the test. If they have an ERCP, it does place them at risk for cholanginitis, pancreatitis, perforation, and sepsis. So treatment, we're going to do NPO, IV hydration, correct any electrolytes or fluid imbalances, pain management, IV antibiotics. If they do use antibiotics, it's usually a short course of broad spectrum. Let's see, they're NPO because they can release the cholecystokinin, which when activated can cause the gallbladder to contract and release bile, which because there's that blockage, it's going to lead to more pain and more inflammation. Morphine's usually contraindicated for pain because it can cause the sphincter of OD to spasm, which will also result in pain. Tylenol and NSAIDs, such as ibuprofen, can be used for pain management if it's less severe. And then removal of the gallbladder, so a laparoscopic cholecystectomy may be indicated. After surgery, we want to treat the pain. We want to encourage early ambulation because especially any laparoscopic surgery, it can cause that CO2 is put into the belly, so it can cause that gas, it can cause that shoulder pain, the right shoulder pain. So we want them walking to get that gas moving and get it out. Increase the diet as tolerated and avoid fatty foods. Pancreatitis. So this can be acute or chronic. Right now we're going to talk about acute. So acute pancreatitis is an inflammation of the pancreas that can be mild to severe and affect people of all ages. Patients with a mild case of pancreatitis have no end organ dysfunction and have a low mortality rate. The most prevalent causes of acute pancreatitis are gallstones and alcohol. Acute pancreatitis is a reversible process involving inflammation of the pancreas secondary to the release of pancreatic enzymes that autodigest the pancreas, peripancreatic tissues, and adjacent areas. Patients with acute pancreatitis can present with sudden onset epigastric pain felt in the upper left quadrant or mid-abdomen. It can radiate to the back or the shoulder blades. This patient is usually characterized as being deep. The pain is usually characterized as being deep and very sharp. It can become more intense within minutes of eating foods high in fat. The pain can be constant and severe and last several days. Some patients complain of severe pain when they're lying flat or bending forward. Pain can also be associated with nausea, vomiting, and anorexia. Patients with alcoholic pancreatitis may not have symptoms of pain for several hours or days after binge drinking. The general clinical presentation of patients with pancreatitis include abdominal fullness from gas or bloating, hiccups, indigestion, fever, tachycardia, and hypotension. Laboratory tests used to diagnose pancreatitis include a metabolic panel, so that's your CMP, CBC, and then the big ones for pancreatitis are your amylase and your lipase. So pancreatitis, you're thinking amylase and lipase. Diagnostic tests, we're going to look at our abdominal CT. Maybe they're going to do an abdominal MRI or ultrasound. The purpose of these tests is to evaluate for a presence of a inflamed pancreas. They could also be looking for gallstones and the bile duct obstruction. Specific interventions for the treatment of acute pancreatitis usually include NPO. This prevents the release of pancreatic enzymes. Patients are given IV hydration and pain medications. In general, IV antibiotics are not given to patients with acute pancreatitis. If they have a fever, usually the fever is secondary to the inflammation and not an infection. If it's caused by gallstones, these patients will usually undergo a cholecystectomy. Medications used in the treatment of acute pancreatitis include opioid analgesics for pain, anticholinergics to decrease secretions, histamine blockers, pancreatic enzymes, and antibiotic therapy. Complications for acute pancreatitis are necrotizing pancreatitis. Moving on to chronic pancreatitis. The most common cause is heavy, prolonged alcohol use. So, chronic pancreatitis, we're thinking of our long-term alcoholic. So this is inflammation of the pancreas that occurs when digestive enzymes autodigest the pancreas and surrounding tissues for a long period of time. So because of the inflammation and scarring, the pancreas is unable to make the digestive enzymes necessary for digestion of the proteins and fats or the hormones necessary to regulate glucose, insulin, and glucagon. Fibrosis of the pancreas occurs secondary to the chronic inflammation and further contributes to the loss of pancreatic function. Patients with chronic pancreatitis have upper abdominal pain, which can spread to the back, and it feels worse after eating or drinking. The pain is often constant and prevents the pain from normal daily activities and is often described as recurring epigastric and left upper quadrant pain. The pain is exacerbated by alcohol consumption and overeating. Clinically, this patient can have nausea, vomiting, weight loss, diarrhea, pale or clay-colored stools, steatorrhea, or oily stools. Patients can complain of losing weight despite normal eating patterns. Weight loss usually occurs because the pancreas is no longer secreting those enzymes to digest the food. So this decreases the absorption of those nutrients and causes malnourishment. Diagnostic workup, this is abdominal CAT scan, ultrasound, ERCP to visualize the pancreas. Again, amylase and lipase, whenever we're thinking of pancreas, we're going to think of those enzymes, amylase and lipase. We want those levels. So as the disease progresses, it impairs endocrine functions. The normal functions of the pancreas, serum glucose levels are monitored. Patients might need insulin. Treatment of patients with chronic pancreatitis include pain management, IV fluid replacement, electrolyte management, nutritional support, insulin therapy to treat those high glucose levels because they're not going to be giving off insulin. There's pancreatic enzyme replacement therapy known as PERT that helps with the malnutrition. Patient education, we want to tell them avoid alcohol, do not chew their pancreatic enzymes, they need to take them whole, they should limit their fat in the diet, and they may need a surgical resection in worst cases. Overview of pancreatic cancer. It's the 4th most common cause of cancer-related deaths in the U.S. There's no reliable screening for early detection of pancreatic cancer. The exact cause is unknown, but there's a high association with behaviors of cigarette smoking, diets high in fat, consumption of red meat, fried foods, refined sugars, and nitrates. There's a higher risk of pancreatic cancer in patients with diabetes, chronic pancreatitis, or a family history. Symptoms may not manifest until significant damage has occurred, and these symptoms are usually pain, jaundice, fatigue, and weight loss. The pain is typically described as a dull pain in the epigastric area and the back. Clinically, we're going to do an ultrasound, CAT scan, MRI, ERCP to determine a presence of a mass. The definitive diagnosis is through histopathology, so biopsy. Treatment is chemo, radiation, and surgery, and we're going to need a palliative care consult for this patient. They don't typically do well. Okay, we finished GI. Let's go to musculoskeletal disorders. Right, we're going to go over muscular dystrophy, strains versus sprains, fractures, compartment syndrome, fat embolism, bone cancer, osteoporosis, osteoarthritis, joint replacement, osteomyelitis, amputation, and assistive devices. Muscular dystrophy. This is a disease with many, I think there's a lot of different subtypes that affect certain muscle groups. They're age specific in relation to presenting symptoms. They have variations in severity and are caused by a defect in different genes. The primary symptoms, The primary symptoms are progressive muscle weakening, wasting of skeletal or voluntary muscle groups. Depending on the type, this can progress really fast or have a slower progression. With progressive deterioration and weakness to the facial, limb, and respiratory and cardiac muscles, the ultimate result is muscular damage. This is caused primarily by the lack of a key protein called dystrophin to maintain the integrity of the muscle fibers, as well as the ability to repair muscle tissue while it breaks down and/or deteriorates. So muscle bulk is reduced. It results in fat and excessive scar tissue. Because of the progressive muscle wasting and weakness, falls are often associated with MD, which puts patients at risk for fractures. Progressive deterioration of facial muscles is associated with problems with dental hygiene, speech clarity, and articulation. As a result, immobility, GI dysfunction is often associated with MD. And the most life-threatening result of this progressive deterioration is cardiopulmonary compromise. The gold standard diagnostic for MD is a muscle biopsy. Treatment of MD focuses on prevention of disease progression and maintaining function. There's no specific treatment. However, glucocorticoids are often used in conjunction with supportive and collaborative care. Strain versus sprain. So what is a strain? A strain is an injury to muscles or tendon tissue. Tendons connect to muscle to bones. A strain is a tearing or stretching of a muscle or tendon, often resulting from overextension, overexertion, or overstretching. Strains can be categorized according to their severity. A first degree, it demonstrates minimal inflammation and pain. Symptoms can last for several days, but range of motion remains unaffected. A second degree strain results from actual tearing of the muscle and tendon fibers. This injury is often painful with severe muscle spasms, extensive inflammation, ecchymosis or bruising that appears several hours or days after the initial injury. Symptoms can last for several weeks. A third degree strain includes the rupture. So third degree is the rupture of the muscle or tendon, causing considerable internal bleeding, pains, inflammation, and ecchymosis. Surgical care may be needed if there is extensive tearing to the muscle or tendon. What is a sprain? A sprain is an injury to ligaments. Ligaments are segments of connective tissue that secure bones to bone and bone to cartilage. As in tendons, a sprain is defined as a stretching or tearing of a ligament resulting from overextension, overexertion, or overstretching. Sprains are also classified similar to strains on the basis of severity. So first degree or a mild sprain is demonstrated by stretching and or minimal tearing of ligament fibers. Edema and pain may be evident, but joint function remains intact. The patients are able to ambulate with slight discomfort. A second degree or a moderate sprain results from a moderate amount of tearing in the ligament fibers. The joint remains intact and the ligament is not completely torn. There will be an increased swelling, ecchymosis, pain, altered weight bearing will be evident in these patients. A third degree sprain includes complete tearing of a ligament, which renders the patient unable to ambulate because of joint instability. Symptoms include severe pain, ecchymosis, and edema. So we want to be able to differentiate strains versus sprains, but also the different degrees, okay? The treatment, this is the easier part. The treatment for them is relatively the same. So for first and second degree strains and sprains, we're going to rest the injured extremity for as long as 72 hours to allow ligaments or tendons time to heal. We're going to apply ice for no longer than 30 minutes, 3 to 5 times per day for 24 to 72 hours after injury. This will promote vasoconstriction and decrease bleeding and fluid collection to the injured area. We're going to do compression. So put an ACE wrap or a similar compression dressing to minimize further swelling. Further swelling delays healing. The dressing should be wrapped tightly, but not enough to alter neurovascular function. We want to ensure that circulation, movement, and sensation remain intact. We want to elevate the affected area to minimize dependent swelling. To remember this, think RICE. We want to rest, ice, compress, and elevate. Functional support in the form of braces can be used for 4 to 6 weeks and are preferred versus immobilization. Exercise therapy programs can also be prescribed and consist of neuromuscular and proprioceptive exercises. In addition to the therapies mentioned previously, NSAIDs are usually prescribed to help with pain and inflammation. Third degree strains may require surgical repair of that torn tendon or muscle. What is a fracture? A fracture is defined as a disruption or a break in the continuity of bone. There are numerous classifications of fractures that you can see on table 54.1. They're assessed by appearance and confirmed by X-ray or CAT scan. A displaced fracture is when there's a malalignment of bone fragments at the fracture site. Treatment is typically an ORIF, which is an operative open reduction internal fixation, and that's followed by immobilization with a cast and splint. Open reduction requires a surgical incision, and it enables the surgeon to accurately visualize the wound, and then they can ensure proper alignment. Internal fixation requires the use of plates, screws, rods, and or other hardware to realign the fractured bone segments. Once the ORIF is completed, the hardware does stay in the patient, and it's only removed if there's a case of osteomyelitis. After the ORIF, the patient's still at risk for infection. The risk for infection is particularly a result of the initial fracture, so prophylactic or preventative antibiotics should be given. Non-displaced fractures are when bone fragments are well approximated within the site of disruption. This can be treated with closed reduction or immobilization with a splint or cast. Traction. This can be used in conjunction with any of the other previously mentioned forms of fracture treatment. Traction involves the use of weights and force to reduce the fracture and relieve symptoms. Traction would be done prior to surgery. Skeletal traction is when pins, tongs, screws, and wires are surgically secured to the bone, and weight is then applied to provide realignment. Skin traction uses flexible harness, boot, or belt externally to secure the extremity, while 5 to 10 pounds of weight is applied to relieve muscle spasms and maintain the length of the bone. Buck's traction is a form of skin traction, commonly used for femur and hip fractures. It helps prevent muscle spasms and pain. It's used as temporary treatment until surgery is performed. Compartment syndrome is a rare but serious complication when undetected can cause permanent loss of the affected limb due to neurovascular compromise. This is caused by an increased pressure in the extremity. Compartments are composed of muscles, nerves, and blood vessels. These compartments are surrounded by a tough connective tissue called the fascia. Compartment syndrome occurs when there is an increase in edema or hemorrhage within the compartment space, which is under the fascia. It can be caused by extended compression from casts and splints. The most common symptoms of compartment syndrome are the 6 P's: passive pain at rest, along with pressure, paresthesia. Then the 3 late P's, or late symptoms, are pallor, paralysis, and pulselessness. The patients may complain that their cast feels like it's getting really, really tight. They complain of pain out of proportion to the injury, and they may complain of numbness. Once compartment syndrome is suspected, the nurse should immediately notify the provider. Immediately. So you suspect it, you call. If caused by pressure from a cast, the provider will remove that cast immediately. An immediate fasciotomy is indicated in the case of internal pressure from edema. A fasciotomy is a procedure in which the surgeon makes an incision on both the medial and lateral aspects of the extremity down through the fascia, relieving that compartment pressure. What is a fat embolism? A fat embolism is a rare complication after orthopedic surgery or injury. Fat emboli frequently manifest in long bone fractures, where particles of exposed fatty bone marrow have migrated into the systemic circulation. The particles then mobilize throughout the body and clog smaller vessels, producing little petechiae. So that's like a small little pinpoint red dots. They could be purple on the skin. Much like VTE, fat emboli can travel and lodge into the pulmonary artery and become a pulmonary embolism, which is potentially deadly. As a result, patients can experience symptoms of respiratory distress, acute confusion, and restlessness, potentially leading to respiratory failure and patient death. If you suspect your patient has a fat embolism, call the doctor immediately. This is an emergency. Lack of treatment, again, can result in respiratory failure and death. Bone cancer, specifically osteosarcoma, can occur in all age groups. The prognosis is poor in older adults. Signs and symptoms the patient may have are pain worse with motion and unrelieved by rest, a limp, swelling, decreased range of motion, and fractures. The definitive diagnostic study is a bone biopsy. The primary objective of medical management is to destroy or remove the tumor. The ultimate goal is treatment is limb salvation, survival, and maintenance of quality of life. Treatments can range from radiation to chemo to surgical therapy. Pain control is another significant goal of treatment. It could be NSAIDs, it could be Tylenol. Commonly, narcotics are necessary to help manage the pain. PT/OT are necessary, and social work and case management should be on board. These patients can be struggling with this diagnosis, especially if the prognosis is poor. So we need to make sure that we offer them support for their treatment, but also support, if they're nervous and whatnot, we need to refer them to social work. Osteoporosis. This is a loss of bone density where bone reabsorption increases and bone formation decreases. It's common in older women. Risk factors of osteoporosis include female gender, postmenopausal, age, sedentary lifestyle, use of corticosteroids, thyroid hormones, and absorption issues. Signs and symptoms of osteoporosis are fractures, falls, low back pain, neck or hip pain, kyphosis, which is that humpback, which also causes height loss, and fear of falling. Osteoporosis is diagnosed using a HIDA scan or a bone density scan. Treatment and prevention include weight loss, muscle strengthening exercises to reduce incidence of falls and fractures, a healthy lifestyle and avoidance of smoking and excessive alcohol, bisphosphonate, which helps with bone reabsorption of calcium. Calcium and vitamin D supplements can help prevent osteoporosis as well. Scoliosis. So in scoliosis, there's a sideways curvature of the spine that's greater than 10%. Signs and symptoms, there's that obvious sideways curve of the spine. The patient will also have uneven shoulders, so one shoulder blade will appear more prominent than the other. They can have an uneven waist, so one hip is higher than the other. To the right on here, you see the Adams forward bend test. This is a visible inspection. So scoliosis is done via visible inspection, radiographical imaging, and quantifying the curvature. This test, the Adams forward bend test, is to observe the patient. So as a nurse, we go behind the patient and we have them bend forward at the hips until their spine is parallel to the horizontal plane. And then we're looking for that lateral curve in the spine. Trying to get fancy here. Treatment is thermal therapy, physical and occupational therapies, a progressive exercise regimen, and pain management. Pharmacological intervention focuses on comfort and pain relief. From my understanding, we have already gone over osteoarthritis. So just quickly, it's a degenerative disorder of the joints. It's caused by the breakdown of cartilage between the joints. Risk factors are obesity, old age, certain occupations like heavy labor ones, and genetics. Signs and symptoms, these patients will have pain, stiffness after activity, usually getting better like 30 minutes to an hour after. Functional impairment, you'll see your old ladies with those bony enlargements on their fingers. Treatment, there's orthopedic devices, so splints, braces, knee braces. We can give them canes or walkers to help them with walking. Encourage exercise, weight loss, PT/OT, and pain medications like NSAIDs or Tylenol, so like your ibuprofen or Tylenol. Other treatment for this could be a joint replacement. Joint replacement, or arthroplasty, is most commonly associated with the joints of the hip and the knee, but it could include any and all joints within the body. We're going to mainly focus on the knee. Osteoarthritis is a leading indication for joint replacement. Diagnosing or determining the need for a total joint replacement is based on deformity, tissue destruction, and loss of function of that specific joint. The need for replacements confirmed by X-ray and MRI. After all methods of avoiding replacement of the joint are exhausted, the doctor decides it's time to replace the joint. Replacing a joint will decrease symptoms and increase quality of life, but it does not come without risk. The most immediate post-operative complications are hypotension, bleeding, and hypovolemia due to excessive blood loss during surgery. Wound site infection is another potential complication. Intraoperative and postoperative adherence to asepsis with washing hands, proper emptying and cleaning of the drain, and monitoring temperature and white blood cell counts are simple measures to help prevent wound site infection. Additionally, antibiotics are given with 1 hour of the surgery, and prophylactic antibiotic therapy should be considered protocol until the drain is removed. Even with administration of the antibiotics, this patient is still at risk for infection and must be taught the signs and symptoms of infection and know to report to the nurse or doctor promptly if they have any signs or symptoms of infection. What is osteomyelitis? So osteomyelitis is inflammation of the bone typically related to infection. Clinical signs and symptoms are pain not relieved by rest, swelling, tenderness and warmth at the site, fever, nausea, chills, general feeling of being unwell. Diagnostics we use are white blood cell count. There would be an increase, ESR, that's our inflammation, right, as well as our CRP, there'd be increase. We could have positive blood cultures, and we would do an x-ray, but if that's normal, we would do a bone scan, and that's the definitive diagnostic for osteomyelitis. The treatment includes antibiotics. If they fail antibiotics, then they would move to surgical debridement. After surgical debridement, they would do more IV antibiotics for 4 to 6 weeks and opiates for pain management. So what is surgical debridement? Right, so it's removal of the dead, damaged, and infected tissue to improve the healing and potential of improve healing of the remaining healthy tissue. After surgical debridement, we want to monitor the CMS. What is CMS? So we want to monitor the circulation, the motor, and the sensory. So circulation. So we're going to be checking our pulses. We're going to check our calf refill. Hey, can you wiggle your toes? We're checking our motor to make sure that they can still move. Sensory. Do you feel this? Do you feel my touch? So CMS assessments are the big thing to monitor after surgical debridement. Now, next would be amputation. 2 types of amputations. There is traumatic. I was, riding my motorcycle, I got in an accident and my leg was chopped off. That's a traumatic amputation. Then there's also our elective, which is our surgical. So amputations, the severing or removal of the body part, generally involving the extremities. For elective, all possible medical interventions to reestablish perfusion are used prior to performing an elective amputation. Big complications, so for that traumatic, we're thinking hemorrhage, but we're going to focus more on these elective ones. Infection. Infection in older adults with peripheral vascular disease who are undergoing elective amputations is a huge potential complication. These patients are at increased risk for developing osteomyelitis and infection of the tissue. Contractions may occur. This is because of loss of bone, nerves, and muscles. They're often seen in patients with lower extremity amputations and are manifested by lack of movement and exercise in that residual limb. They can be avoided by encouraging the patient to perform active ROM exercises, range of motion exercises, and participate in PTs. Phantom limb pain. Phantom limb pain. Common complication of amputations. So this is when they feel like numbness, tingling, or sharp burning pain. Like they have left BKA and they're like, my left foot hurts. And you're like, you don't have a left foot. Don't say that to them. But so this is that phantom limb pain. They feel something even though it's not there. There's multiple theories on why this happens, but none are 100% proven. If you look in your text, I don't have the page number on me, but if you look in the text, I'll explain the different theories. You don't really need to know that. Just understand what phantom limb pain is. The pain typically weakens over time, but it can be exacerbated by touching the residual limb. Weather changes, stress, nervousness, exhaustion, further sickness can exacerbate that pain. The administration of antidepressants and anticonvulsant medications, such as gabapentin, that's the big one I most commonly seen, is used for treatment of that phantom limb pain. Neuromas are another complication, and that's a clump of nerve axons in the distal end of the residual limb. There's really no way to prevent that. It's just kind of inevitable. Emotionally, these patients, they're grieving. Think of what they lost. They didn't just lose part of their leg. They lost their lifestyle. They lost, yes, they're going to have body image, but like, let's say there's someone who liked to walk. They can't really walk well anymore. Like, they're really sad. So please be empathetic, provide support, offer resources, refer them to a support group. Keep in mind, like, they may not be comfortable even looking at their leg. They may not want to talk about it. Another thing, just backtracking with that infection, signs and symptoms of infection for any type of wound, whether we're talking about amputation or we're talking about joint replacement, when we're teaching them signs and symptoms of infection, that's that increased or purulent drainage, redness, warmth, and increased temperature at the site, Also, yes, there's systemic fever and whatnot. We need to know them, and we need our patients to know them, okay? Last slide. So we're almost done. All right, so assisted devices. Again, this is a review. I like this little thing on the left here, canes and walkers, cane opposite, affected leg. So if my right leg is injured, I should be holding the cane with my left hand. Okay? Now, if I'm walking with the walker, I should be leading. So move the walker, my weak leg, then my good leg. All right, so where does the nurse stand? The nurse stands on the side of the affected limb. So if little Granny Becky hurt her right leg, you should be standing on the side of my right leg. So you should be standing on my right side, and I should be holding my cane on my left. Okay? So little things that I remember, my first job ever was ortho, and I remember every time I walked a patient, I'd be like, walker, bad leg, good leg. Walker, bad leg, good leg. And I just say it over and over in my head to make sure that they were doing it right. You don't need to do that, but just remember, walker, bad leg, good leg. Or cane on the opposite side of injury, and you as the nurse is always on the side of the injured leg. Okay?